Oh, lovely. Will that do? Can people hear me?
The position, yes. No,
No?
they didn't
Okay.
watch.
Right, so my name is Kat. I'm one of the specialist nurses that worked in Oxford. So my area of expertise is stoma care. So I do that all day long, which is great. So me and Alison are both working together, but kind of we don't really do the same jobs. So we've kind of done one then the other. So mine kind of leads on to Alison's. So we're just going to talk about what is anal rectal malformation, what is a stoma nurse, what is a stoma, and a little bit about stoma care. So a lot of these pictures are from Dr. Google. So sadly they are not all ones that are patients of mine. So anal rectal malformation is a spectrum of anal absence or abnormal position. And it's IA is congenital malformation in which the anal rectal region is incompletely developed at the time of birth, which I think some of the colleagues here have really explained in a lot of depth, so I won't sort of go into too much with that. So this requires emergent surgery for the formation of a colostomy. So that's sort of when I come in after that. So to start with, I meet parents that are very stressed out. They've sometimes had a really horrible first few days of their newborn. And hopefully I'm there to make that feel a little bit better. So again, we sort of talked here, occasionally there could be a fistula from the bowels and other areas, giving the impression that there is an anus that can be missed sometimes at birth. I think sometimes we've seen them, sometimes even a week later, that they kind of present. Do you agree with that, Alison? Occurs in 1 in 5,000 births. So I had that statistic on a different presentation before all of this came about, so it's quite I thought I'd leave that in there, even though you all know that. So requires further reconstructive surgery as an infant, often within the first 6 to 9 months. So again, what colleagues have said about variations depending on other factors. So this is a little bit about me. So my job is to teach parents and carers how to manage their stoma care. So just in essence, normalising things. So talking through what's going to happen in this scenario and that scenario. So in my role in Oxford, if the child is from Oxford, I will continue into the community. If not, I will refer out into another specialist nurse team. However, we do all work very differently depending on the area. So that's something that you may find that maybe wasn't as seamless if you're from a different county. I think continuity is absolutely key in these scenarios. So I really try, if I meet a family, I really try to be the one that their main sort of port of call. Although I am one of 8 nurses that do my job in Oxford, so it can be a bit of a mismatch. So ideally, it would be the same person. We liaise with other multidisciplinary teams, so myself, Alison and Silke, who sadly can't be here. I think we've got a really good rhythm at the moment of kind of doing it all together. And also we do things like discussing activities of daily living, bathing, things like that, which I'll sort of touch on again in a moment. So what is a stoma? So this is a little Oxford baby. I do have permission to use this picture. So a stoma is an umbrella term. So it's a Greek word used for mouth or opening. So you might find that people say stoma and it might mean a lot of different things to different people. So the most common types of stoma are an ileostomy, so that's a small bowel stoma, a colostomy, which is a large bowel stoma, so much further around the digestive system, or a urostomy, which is a urinary stoma. So in this setting, we're talking more about the colostomies. So this is a split stoma, so this is already going to be controversial from what everyone has already been saying. So this is sort of a classic Oxford stoma. We do occasionally get a loop, but the majority of them are split in this respect. And that's really surgical technique, surgeon's preference, and I think also as well it may be sort of dependent on the child and what their shape and everything like that. So I wouldn't ever tell a surgeon what to do because I think they know a lot more about it than I do. So although we're saying colostomy and mucus fistula, in theory they both are colostomies because it's both is the colon. But generally we find that the distal part, so we've got this is normally the active one and this is normally the inactive one. And again, it may vary, but this is sort of a general look. So in Oxford, our surgeon likes to defunction that lower end. But again, controversial, so I'm not going to go into that anymore. Stoma care. So ideally, I would get a couple of days with a family to explain sort of how to do everything. sadly, as with a lot of the things that we've been talking about, there isn't a lot of funding when it comes to these sorts of issues. So in paediatric stoma care, we've probably got about 5 options in terms of bags. And mostly I think that's because it's really challenging to get researching things on small people, and also to trial things again, and also they don't make a lot of money because a lot of these children don't have permanent stomas. So it's finding a balance, but I think there are some things coming through. So I think Coloplast are launching a new neonatal/paediatric bag. I don't know if that's official or I'm telling you top secret things, but that will be coming soon. But a lot of the products that we use are adult products that we adapt for children. So sometimes it needs a little bit of creativity, and what works for one child might not work for the other one. So it's finding a very individualised system of what works. So depending on what the stoma looks like, where it is, and what products we've got that we can use. So my little hints and tips, be very organised. So always have your next bag ready. Bath time can be a really good time, because a lot of new babies, you want that routine, don't you? So actually sometimes babies are nice and chilled, generally, after a bath. So that can be a really good time to do your changes. Also, you can bath without a bag on. That is absolutely acceptable, and I would encourage it. Mostly because if a child's going to poo in the bath, you don't have a lot of control over that, regardless if they've got a stoma or not. And I think it can be very cleansing as well. So again, be organised, make sure everything's ready before you start. Little things like applying bags this way, so you can empty it into the nappy a bit more easily. And also, if you've got a stoma or a child with a stoma for potentially 6 months, it's really important to have ongoing reviews with people like me, because things do change massively. So size, shape, little scars in between the 2 stomas that were a little line can become a crease. And parents sometimes express to me that they're doing exactly the same thing they've always done, but they're getting these ongoing issues. And actually I can take one look at it and say, oh, let's try this. So it's really, really important. So it's never an issue to review somebody again. It's what they pay us for, really. So that can be really helpful, just to know that you can contact your local teams. And if you don't know who they are, then nab me afterwards and I can take your contact details and try and point you in the right direction or answer any questions that you might have. So that's a real whistle-stop. Oh no, one more. So common concerns are things like sore skin, bag leakage. Again, those are things that a review can really help with. Bathing, swimming, so as Cassie's already said that they swim as usual. So I think that's one of the things in my job is reassurance and talking about, you know, what is possible. So I think parents are really scared that they're going to damage things and things like that. So always contact your stoma nurse as much as you need to. There is conjugate nappy on the inside or the outside. I just say tuck it in and get on with everything, really. So I hope that, so I'm going to pass you over to Alison now.
It's now officially lunchtime, so I'm going to be really quick. I just say while Colin's setting that up, just I'm getting a nod from Rebecca. Do you want me to do anything else?
Come in and see.
It's just, I'm so proud to be here today. I am a surgical nurse in Oxford, and when I walked in today, I have to say I did shed a tear, because my dear work families, there's so many of them here, and I'm so proud of what they've achieved. I shouldn't be proud of what they've achieved because they are incredible people. And I started this job in 2015, and so just the year before Eric had been born. And so I worked on the ward as a surgical nurse, and so I met Eric, Rebecca and Colin. But when I started my job in 2015, I think they probably came with me as probably the biggest learning curve in my life. I certainly didn't have all the answers, I still don't have all the answers, but just to say I'm so proud of you guys, and I'm not amazed really that you have pulled this off. And so Cassie and John, it's just lovely to be here. Thank you. My role is kind of to try and do a bit of everything for everybody if possible, but really my main thing today is just to go through this kind of scenario, which is our biggest problem often post-stoma closure. Some babies get through really quickly without any problems at all, but I know one or two, it's kind of our biggest point of tears and frustration for quite a few weeks. That's kind of a fairly frequent scenario, and I know it's quite tricky to treat. We can go through skincare if we need to. We can go through research if we need to. In Oxford, we have our algorithm that we work with tissue viability to try and treat skin and bottoms. The principle really of bottom care is not to change the skin pH too much in order to prevent skin breakdown. But how we do that can be a different thing for each different baby and child. So we often try and clean with olive oil and not water, and that's to maintain the skin pH. We try and reduce friction as much as possible. So some mums, I know, just kind of stick bottoms under taps and let the water wash things off. And we have Medi-Honey, we have various different products. So we usually start in Oxford plastering your poor babies with stuff as soon as they come back from theatre. Our frequent combo really is Metanium with one of the more silicone-based products to just get things to spread and cover really easily. I have my favourite, which is stoma powder, which kind of is a joy. It really gets into the little places that your finger and creams can't get to, and you can blow it off and it sticks to all the wet areas. And Kat is brilliant in supplying me with secret supplies of stuff when I need it. So that's our usual kind of stores stock. That's a post-stoma closure baby, one of my little friends, 10 days. All the sort of tried and trusted hadn't worked on that little lady's bottom, and so we moved to Ilex for that little one. Ilex has its own problems because it will stick to the nappy and pull your kind of skin off if it's not used properly. So you do have to know how to put it on. So I'll quick whiz through these slides, just give you a quick guide as to how to put it on. And I'm very grateful to my little mum here, not my little mum, my little bottom and my mum, for making this for me. So if you warm your Vaseline, it goes on over Ilex even better. And that is that little bottom that's healing. But again, it doesn't work for everybody, and I know it certainly didn't work for Eric at the time, so we had different things. Stoma powder probably came as your rescuer. There were other things out there, and you're all very welcome to try and tell me any remedies that work. And of course, it's all your experience that makes my experience and changes the advice or helps the advice that I can give to other people. So also, as well as doing bottom care, just to kind of continue, obviously I help with in the clinics we discuss continence, and then I can extend my role into school age as well, supporting children at school, supporting with continence issues and sort of irrigation systems to maintain bowel continence. So it's kind of I'm learning still. We kind of haven't got any time for some questions, but maybe this is our poster for, I don't know, for raising funds. He's got a cute bottom. Thank you.
It's lunchtime now, everyone. If you've got children next door, if you could go get them, please take them to lunch with you. We'll see you back here at 1:30. I think the doctors... Joe's going to talk.
The medical professionals will be in here at 1:15. So once you've had your lunch, if there's any particular one-to-one questions you were keen to ask, then please come back a bit early. We'll stick around here, and if there's any questions you want to pose to us before we start at 1:30.
And don't forget your post-it notes on the timeline. 1:30, that's going to be taken down. Greg might be selling his book during lunch. It's your chance to get your signed copy. Cash only, please, £10.
That's right. It's a good deal at half the price. How you feeling, sweetheart? Finish that one.
May I?